Sure. Assalamu alaikum wa rahmatullah. My name is Saad al-Sheikh. I am stroke neurologist practicing in Saudi Arabia. I'm the Stroke Fellowship Program Director in Prince Sultan Military Medical City in Riyadh. And it's my real pleasure to welcome you all to this 42nd MENASO Education Academy Cerebrovascular Grand Round Series and the sixth webinar for this year. Today's session aims to explore certain complexities of cerebrovascular medicine with a group of distinguished speakers and experts through exciting topics, debatable ones, and challenging case studies presentations. Allow me, please, to welcome my co-chair and dear friend, Dr. Nuran Tahir. Dr. Imran Tahir is a stroke and neurology consultant at the Ministry of MNGHA Riyadh and a stroke fellowship director at King Abdulaziz Medical Cities Riyadh. She served as a member of the Ministry of Health Stroke Committee in the Western region, a stroke project leader at KMCJ, Neurology Program Deputy at KMCJ as well, and she was the chief resident in the National Guard of Health Affairs Jeddah. Dr. Nuran finished her bachelor degree from Medical College in Taiba University in Medina in 2009 and completed her residency training in adult neurology in King Abdulaziz Medical City National Guard Health Affairs. Welcome, Dr. Nuran.
Thank you so much, Dr. Sada, for this nice introduction. And I believe now everyone knows my age. Uh,
Yes,
okay,
I put
so
it very clear. I put it very clear, honestly.
okay, so thank you for that. So let me introduce you, Dr. Sada, so we can start. And I'm glad and honored to be with you all here today, Dr. Sada, Dr. Demchuck, and Dr. Hani, to discuss interesting cases and topics. So Dr. Sarda is a dear friend and she's a consultant of neurology and also stroke at Prince Sultan Military Medical City in Riyadh. And she's here in Saudi Arabia or in this hospital since 2018. She's also the stroke program director there, and she's an active physician who had graduated from the University of Khartoum with the best performance academic prize at that time. I wouldn't mention the year.
Good.
Okay, so okay, so Dr. Saad, I will leave the floor for you to introduce our first speaker, please.
Thank you, Dr. Imran. And welcome, Dr. Demchok. It's my pleasure and honor to introduce our first guest speaker, uh, a stroke expert, and of course, a figure in the field, Dr. Andrew Demchok. Dr. Andrew is a professor in clinical neurosciences at the University of Calgary and director of Calgary Stroke Program. He earned his medical degree with distinction from the University of Saskatchewan in 1993 and completed a cerebrovascular fellowship in Texas. His research focuses on vascular imaging for stroke treatment. Dr. Demchuk has chaired the Heart and Stroke Foundation of Alberta and serves on various stroke committees. His awards include the Michael Pesant Stroke Leadership Prize and the Case W. Brownell Neurology Teaching Award. He holds a Scholar Award from the Alberta Heritage Foundation for Medical Research. Dr. Andrew will be discussing today the current understanding of cryptogenic stroke. Without any further delay, looking forward to hear from you, Dr. Andrew, and the floor is yours.
Thank you very much. It's a great pleasure to speak here on behalf of MENASO and your academic program and academy. I've got a big topic here, so I'll try to work quite quickly through it and leave a little bit of time for questions. Cryptogenic stroke is a fascinating area. As a stroke neurologist, most stroke neurologists like the acute work that we do, but we went into neurology because we like to localize. We like to be a bit of a Sherlock Holmes And I feel like in the area of cryptogenic stroke, that's where we still get to do that as stroke doctors. These are my responsibilities, conflicts, and disclosures. I'll start by quickly describing the definitions that are relevant here, like ESUS and cryptogenic stroke, workup, etc. So remember that cryptogenic stroke is a broad subtype of the sort of five main etiologies of ischemic stroke: large artery atherosclerosis, small vessel disease, cardioembolic, unusual or other, and then cryptogenic. Nowadays, we've moved away from the term cryptogenic and have replaced it with the term ESUS. And the way to think about ESUS is it's a subgroup of cryptogenic. Cryptogenic historically includes patients where you do an incomplete investigation or you find more than one plausible cause. ESUS is neither of those two. You have to do a complete investigation and you can't have more than one plausible, you can't have any plausible cause, essentially. These are the key workup elements for making a diagnosis of ESUS: brain CT or MRI, ECG, echo, 24-hour Holter, and some form of both intracranial and extracranial vascular imaging. Essentially, an ESUS stroke is one that is not lacunar, does not have an associated symptomatic 50% luminal stenosis in the supply of the territory that you think the symptoms relate to. There has to be no major cardioembolic causes and no other specific causes of stroke. And so the non-lacunar essentially means that any small subcortical lesion less than 2 centimeters in maximum diameter on MRI would not be considered an ESUS stroke. And when you think about the luminal stenosis, so a small, lesser than 50% could be considered ESUS, but an over 50% lumen, no. And then you have the major cardioembolic causes, which are listed there: atrial fibrillation, a flutter, intracardiac thrombus, prosthetic valve, mitral myxoma, mitral stenosis, recent MI, poor LV function under 30%, vegetations, and endocarditis. So that's essentially the grouping. So if we look at these 6 strokes on MRI, do they all classify as ESUS? No, the one in the top left corner would not be considered an ESUS stroke because it's too small. The others could be if no other demonstrable cause is identified. So when we think about what is ESUS stroke, what is cryptogenic stroke? Is it arteriogenic from vessels, or is it coming from the heart? Like, what are we missing? And it looks like, if you look at some of the proteomics work, that the signature for a cryptogenic stroke looks a lot like a cardioembolic stroke. And the clots that we retrieve in cryptogenic stroke are very similar to cardiobolic stroke. So I think the majority, maybe the vast majority of these cryptogenic strokes are in fact hidden cardioembolic sources. But there are, I think, certainly arteriogenic events, and I would even argue there are paradoxical embolization events that we're also perhaps not appreciating. In terms of randomized clinical trials of antithrombotic therapy with ESUS, there have been 4. The first was the Navigate ESUS trial, which did not demonstrate any benefit of rivaroxaban over aspirin, with an increase in bleeding with rivaroxaban over aspirin. We have the Respect ESUS trial, which overall was a neutral trial, but did show some separations of the curve after 1 year that suggests maybe there's a future role for anticoagulation. The bleeding was similar for dabigatran than aspirin in this trial. What was quite interesting in Respect ESUS is that the low-dose patients randomized at the 110 BID who are over age 75 showed a statistically significant benefit in favor of dabigatran. So there may be a value to anticoagulation at a lower dose regimen in this setting, but this was, of course, a subgroup analysis. The next trial was the Atticus trial, which showed no difference between aspirin and apixaban for recurrent stroke risk, but there was a trend toward reduced composite endpoint events, and there was a very a reasonable safety signal with less, or a trend toward less major or clinically relevant non-major bleeding, although there was an increase of minor bleeding with apixaban over aspirin. And then lastly, the recently published Arcadia trial, focusing more on atrial cardiopathy, which showed no difference in with apixaban over aspirin in these ESUS patients, but a trend toward less major hemorrhage events. In fact, there were no symptomatic intracranial hemorrhages with apixaban and 7 with aspirin, which is quite interesting when you think about it in this trial. So safety looked okay. In terms of ESUS, I like to subtype ESUS in what I call soft etiologies. What I mean by that is that in the old days, we used to think 25, 30% of patients were ESUS or cryptogenic stroke. But now, with the incorporation of advanced investigations, we've shrunken down that cryptogenic, undetermined, or ESUS group of patients to be much smaller, maybe 10, 15% of all patients now. So we have to think about all of these various ESUS subtypes or soft etiologies and start digging into these when we have a possible ESUS patients. If we don't dig into these, we're going to miss something that I think increasingly has implications in management. So let's go through a few of these very quickly. One is carotid webs. These have been detected now very frequently with CT angiography of the neck, a web-like structure right at usually just above the bulb of the carotid, which tends to produce a stagnation of flow. Young patients have webs in up to 10% of cryptogenic stroke. So in young cryptogenic stroke, think web, and do look at that carotid bulb. They have essentially a stagnant column of blood, which allows the RBCs to clot off. And you can see this when you do an angio run in a web patient. There's huge stagnation of the contrast after several seconds of an injection. So the blood is really a little sludging in these locations. We don't have randomized trial what to do for these patients, but in observational studies, fascinatingly, medical management tends to fail with recurrence, while carotid revascularization seems to be curative. And that's phenomenal, right? We probably need some randomized data to really change practice in this, but all the observational data is pointing toward addressing the web by removing the web surgically or by stenting the web. But it needs confirmation in a randomized trial, ideally. Mild non-stenotic carotid plaque, or SINC, is a phenomenon where plaque can build up with compensatory enlargement of the vessel without luminal narrowing, resulting in a stenosis over 50%. We know that the thicker that plaque, the higher the risk that lesion is. And more likely it's the etiology of that so-called ESUS stroke. And you can measure this very nicely now on CTA because essentially most of these plaques have at least some calcium in them to give you the outer wall diameter. And so you can calculate these things very easily. And there's been excellent studies now looking at the so-called rim sign, where you get a circumferential appearance of calcifications, or you can measure that diameter of plaque and then what's remaining for a luminal diameter with contrast. And these have been predicted to be strong predictors of high risk and even intra-plaque hemorrhage. Aortic arch disease can now be nicely graded by looking at the degree of calcification in the wall of the arch. Again, this is also available on a CTA of the neck and head. We routinely get arch information as part of our CTA of head and neck. And sometimes you'll get severe protrusions or ulcerations that place this arch disease as more serious. And we now have data that the more complex or the grade of arch, the higher the risk of stroke recurrence. Fast MRI can be particularly helpful when you have a SINC, a non-stenotic carotid, or an aortic atheroma, and you're wondering whether this could be a so-called arteriogenic cause of ESUS. The typical carotid SINC will have multiple diffusion hits in one vascular territory, sometimes numerous hits. And the aortic arch disease patients will have bilateral hits, often more on the left than on the right, but small and scattered, and often both acute and chronic. So these are very helpful diffusion patterns when you're thinking arteriogenic. Whenever I see only one vascular territory, multiple hits, I always think arteriogenic. Atrial cardiopathy is another cause, and this is where the transthoracic echo is important. You can look, you'll see left atrial volume increase often reported on echoes, 7% of stroke echoes. And we can correlate that now with an increased stroke, heart failure, and mortality risk in patients, the higher the left atrial volume is. And you can do something called the left atrial volume index. 38 or less is normal, above 38 is abnormal. And I've seen some patients fail DOACs that can have left atrial volume indexes of 150 or 200, massive left atrium. There's some suggestion of benefit from DOACs with large left atriums, but this is subgroup analysis and requires further study. Cardiac CT may be particularly helpful in these patients as there is a significant yield of left atrial appendage thrombus by doing a cardiac CT. It would be this type of atrial cardiopathy patient where you see a left atrial enlargement and an ACEs stroke where I would contemplate that. Left ventricular dysfunction or covert LV thrombus. Wall motion abnormalities, again, are roughly around 6% of all echoes post-stroke have wall motion abnormalities. We know they're associated with a higher risk of recurrence, and we know it's particularly the apex that's the most important wall motion location to look for hypokinesis or akinesis, as it's in this region where you get a lot of microembolic signals post-MI. And it's this region that has been associated with stroke risk, cardioembolic stroke risk post-MI, with odds ratios as high as 20 when you look at the apical region. So I really pay most of my attention to any type of wall motion abnormality, especially in the region of the apex. Cardiac MRI is a particularly useful study when you have LV dysfunction or wall motion abnormalities. Patients with ejection fractions around 35% or less have a fairly significant yield for LV thrombus, particularly if the apex is at all involved. And so that's an important concept to consider. And it is the best tool for detecting a left ventricular thrombus. It's superior to an echo and even superior to a contrast echo. So whenever I'm wondering about the apex as the source, I will do a cardiac MRI. Cardiac MRI can also pick up some of the more unusual cardiomyopathies, like HOCM, dilated cardiomyopathies, atrial masses, and even active ischemic cardiomyopathies that could also be responsible for the ACEs stroke. Cardiac MRI is very good for LV thrombus detection, cardiomyopathy, and intracardiac tumor. Covert atrial fibrillation, again, this is prolonged ECG monitoring, and this will be discussed further, I think, in the next talk. One has to be somewhat cautious about this tool, as there is a lot of screening required before one stroke is saved. If you look at the 3 randomized trials of internal loop recording versus not, there is a 5-fold increased yield of detecting atrial fibrillation, but this did not translate into a large effect in stroke prevention. There was, in fact, you have to screen 90 patients to prevent one stroke with this approach. I think there are ways to better refine the population that you do perform prolonged monitoring for. I would focus on older patients with higher rates of AFib likelihood, patients with PACs on their Holter at a significant rate, like 20 an hour, and patients who have pro-BNP level elevations. There's a strong correlation between pro-BNP and the development of atrial fibrillation. There is also smartphone technology that I think can be used as a screen for this. It is not perfect. It is a screen. But if you've got patients, many patients now walk around with these smartwatch, smartphone applications. And so I will encourage this in patients where I'm suspicious of paroxysmal atrial fibrillation. I've done some initial Holter testing, etc., and I want to have them monitor it for an extended period of time and screen for this. I think these technologies are getting better and better. Cancer-associated thrombosis syndrome is also, I think, a very important cause of ACEs stroke and probably should be classified separately now. The classic phenotype is multiple small scattered infarcts in all vascular territories. This is a coagulopathy of the vasculature, and arteries start clotting all over the place with cancer-associated thrombosis syndrome. The D-dimer is a very crucial test that we tend to do on day 2 or day 3 when we're looking for this in ACEs strokes, and the cancer patients will typically always have D-dimer elevations above 3 micrograms per mil. That's almost never seen in normal stroke situations. You'll see mild elevations after stroke, but you'll rarely see them above 3 unless they have aortic syndromes, cancer, or DVT-PE. Those are the 3 clinical settings where you might see very high elevations. We know that this group of patients is the highest risk of stroke recurrence of any stroke etiology. A patient with a high D-dimer and multi-territory infarcts on the MRI have a 40% recurrent stroke rate at 1 month. 40% at 1 month. You just won't see this with other etiologies to this extent. There is now emerging data from a couple of studies that the D-dimer reductions seem to be better with enoxaparin than DOAC. DOAC has been used in patients with cancer-associated thrombosis on the venous side. There are randomized studies supporting this. But in cancer stroke, there are concerns beginning to emerge that maybe low molecular heparin is still the superior approach to these patients. And this has also been shown in a small biomarker study where the drop in D-dimer seems better with enoxaparin, and there may be fewer recurrent events in this. So we need more data. We need large trials here, but from what I can see so far, this may be a low molecular heparin type of treatment regimen for this serious condition. Paradoxical embolization, PFO stroke. Of course, we all know about PFO closure, and we commonly look for PFOs now in our younger patients under 60 to consider closure for them. Please do TCD bubble studies. TCD bubble studies will increase the yield of right to left shunts threefold over echo bubble studies. And we need to be doing TCD a lot more globally. This is a much better test. There are now large studies supporting and very clear evidence that they're superior for detecting these shunts, including the large shunts, which tend to be the ones we like to close. The other area of controversy is, what about PFO stroke over age 60? We have evidence that anticoagulation may be superior to antiplatelet therapy in this setting. And we also have evidence that the PFO stroke patients with very elevated D-dimers are very at risk for recurrent stroke. So I have begun in my practice to check for right to left shunts in patients over 60, especially when they've had an ESA stroke and I can't find a cause. And I have been surprised by how many elderly patients have massive shunts that probably one could either justify another randomized trial if we could do such a thing, or even consideration of empiric therapy in that setting with a massive shunt and an ESA stroke that's unexplained. To finish, I'll just talk briefly about hidden etiologies of stroke. The hidden thrombophilias of stroke. Essentially, this is where you do a CBC looking for thrombocytosis. I picked up some thrombocytosis can sometimes be just a little elevated, and you can have major issues with patients with JAK2 mutations and whatnot. So don't forget the CBC and careful review of that, but also the thrombophilia screen. And I think really the two key parts of the thrombophilia screen are the antiphospholipid antibodies, and there's now a global antiphospholipid severity score, which includes measurement of anticardiolipin antibody, beta-2 glycoprotein, lupus anticoagulant, and one that's not being done much, phosphatidylserine prothrombinase complex. Those are sort of the four main antibodies. The top three are your so-called triple positive antibodies, and we know that they're associated with an elevated risk. So do consider this, particularly in younger patients in the setting of prior miscarriages or with skin rashes like livido, etc. You must consider this. Hyperhomocystinemia is also underappreciated. I've seen a number of young patients with large carotid thrombi, and they have essentially a B12 metabolism problem genetically, and they have extremely elevated homocysteine levels, often over 20. This has been associated with unprovoked venous thrombosis, and there's an increased attention to this now. And then, of course, I'll finish by talking about empiric therapy. This is obviously controversial and not in guidelines, but what do you do when you have a patient with an ESA stroke who recurs on antiplatelet therapy, which is the current standard for this? Do we repeat any investigations? Well, what I do is actually I'll do the D-dimer in this setting, or if I'm particularly worried about even the first ESA patient and I'm going to have the patient follow up, I'll do a late D-dimer, and if it's quite elevated, I'm nervous. And there's now pretty good data that the highest quartile of D-dimer is associated with recurrent stroke risk. So it can give you some idea of which of these patients with ESA strokes you should remain worried about and maybe investigate just a little further or reinvestigate in some settings. I also think this is an opportunity in the future for therapy. in that we have very good data now from 4 different randomized trials comparing apixaban to aspirin, that apixaban is actually a very safe therapy for major bleeding. It has the same or less major bleeding than aspirin. So if you're really stuck and you're trying to, and you've got a clear recurrent stroke on antiplatelet therapy, certainly we've all been in that circumstance where we've tried empiric apixaban. Given it's now a generic drug, it's less expensive, and its safety profile for major bleeding is as safe, if not safer, than aspirin. We are also studying this in large phase 3 trials where combination antiplatelets and a factor 11 anticoagulant is being used, and there are a significant number of ESUS subjects in these large phase 3 trials. So I do think we'll have some data in the next 2 or 3 years about whether we can add a little bit of an anticoagulant like a factor 11 with good safety profile to an antiplatelet, and we may actually see some benefit here, and we need to move on, so we have some strong data, guideline-based data for this approach. So I'm going to stop there. I've got, I think, about 6-7 minutes for questions as we planned, and thank you again for your attention.
Yeah. Thank you, Doctor, for your great lecture, and I'm sure it's provoking for many questions. But if we can kindly leave all the questions, I think we'll have a lot of questions in the Q&A box. Preferably, we'll leave at the end of the talk so that we can give the chance to all the speakers. Dr. Nuran, the mic is for you.
Okay. Again, thank you for that, Dr. Andrew. Very enlightening and fruitful as usual. And I'm glad to start the challenging cases. And the first case today that we will have will be presented by Dr. Nouf Alrishi. Dr. Nouf, she's currently an F2, so she is a vascular neurology fellow at Prince Sultan Military Medical City in Riyadh. She is dedicated in treating cerebrovascular disease, and she excels in her clinical care and research. Today, she will be presenting an interesting case about symptomatic ICA occlusion. So without further ado, Dr. Nouf, the floor is yours, please.
Thank you so much, Dr. Noran, for the introduction. Thank you, MENASO, for the invitation. We are presenting here a challenging case that we had almost 3 months ago. He is a 68-year Saudi gentleman with a history of diabetes, hypertension, dyslipidemia, and a previous ischemic stroke with minimal left-sided residual weakness, secondary to right subcortical ischemic stroke, and MRSF2 with cognitive impairment for 1 year, and the patient has been on single antiplatelet. 2 weeks just before the presentation to our hospital, the patient developed right-sided weakness, which was a transient and frequent episode. And the patient was admitted to another hospital before coming to our hospital, and the workup there revealed left ICA occlusion, and the patient was started on dual antiplatelet, then was discharged. But the symptoms worsened, and the patient started to have the same episode frequently, and upon the presentation to our ER, he had the right-sided weakness and associated with swallowing difficulty. So that was the presenting symptom. When the examination or initial presentation, the blood pressure averaged in 107, the systolic blood pressure to 120, and the blood sugar within normal range. The ECG sinus rhythm, the NIH initially was a 3. And one for the right facial, one for the dysarthria, and the left lower limb drift was old. The initial imaging for the CT and MRI brain didn't show any acute stroke, and the CTA head and neck left ICA occlusion. So these are some cut from the CT brain initially for the patients and DWI with the MRI, sorry, with the flare, and there was no acute stroke, only the white matter disease, periventricular hypodensity, some lacunes, but there was no acute stroke. And here the CTA for this patient, the initial CTA. So with the calcified aortic arch and with the common carotid artery just after the bifurcations, we could see there will be loss of the opacifications by the contrast of the common carotid artery distal cervical segment, then the vitreous portion, cavernous portion. Then till there will be reconstitution to the left MCA. So at this point, for the management of this patient, we started him on IV heparin. We stopped the dual antiplatelet and thought that it could be propagating thrombus at the base of the occluded vessels, at the same time to carry on the investigation. But what we noticed during the hospital course for this patient, whenever the blood pressure, especially the systolic blood pressure, dropped to less than 160, he would develop the symptoms, the same symptoms, the right-sided weakness, and there was some variant other symptoms like slurred speech, swallowing difficulty, or speech arrest. Despite from the presentation, the antihypertensive medication were kept on hold, and at this point, the patient needed some augmentation to his blood pressure, so IV fluid was started in trial to keep the systolic blood pressure more than 160, and we noticed that the symptoms will be recovered completely. So at this point, we proceeded with the cerebral angiogram. And here's some cut for the cerebral angiogram. For the run from the right ICA, the common carotid, and the right ICA, it was okay. And the right vertebral artery, we could see there was no left become for this patient. And here with the run to the through the right carotid system or right ICA, we could see or appreciate the poor collateral to the left hemisphere through the absent A2 and poor ACOM. And here for the left ICA, so we could see there is opacifications throughout the cervical segment, the vitreous segment, but then at the cavernous segment, there will be lack of the contrast secondary to the occlusion. And the supraclinoid segment is mainly dependent on the ophthalmic artery for the retrograde flow or the flow through the ophthalmic artery. So with these are the poor collateral from the right hemisphere to the left hemisphere for this patient with the cavernous segment occlusion of the ICA on the left side. So at this point, we just stopped the IV heparin infusion and switch the patient from the Plavix to ticagrelor as the medical therapy for him. But here came the questions that with symptomatic ICA occlusion for 2 to 3 weeks, shall we go just with the medical therapy? What about bypass surgery? What about endovascular surgery? And if there is anything more that we could do for this patient that could help in evaluating him more. So in our hospital, we don't have the facility for CT perfusion or MR perfusion, so we went with the transcranial Doppler. And when we did the transcranial Doppler, proved again there is a poor collateral from the right side to the left side. And there was poor vasomotor reactivity also in the left side hemisphere. Almost there was no reactivity for this patient. So it proven that there is impaired cerebral hemodynamic at the left side. So we decided to go with the stenting endovascular surgery for this patient. And so here are some photos. We passed the occlusion, the balloon, and there was just approximately, there was also some stenosis. and successfully the stent deployed. And the flow at the left side carotid system all the way from the cervical to the MCA was restored for this patient. And just recently, we saw the patient as a follow-up. So the 90-day follow-up, the MRS score was 2 to 3. Now he's able to walk just like before independently for short distances, and for long distance, he needs some support. So here's some review about the symptomatic ICA occlusion. We came through this article that published recently in January 2024 for the as meta-analysis and systemic review for the endovascular surgery, revascularization for chronic cervical carotid artery. And the prevalence, talking about the prevalence for the carotid occlusion, or carotid disease, estimated to be around 15 to 20,000 for ischemic stroke in the United States. And the risk for the overall subsequent ipsilateral stroke or transient ischemic attack, it could be 7% per year. And interestingly, that this could be increased up to 24% in 2 years for those patients who are in the medical therapy, but they have poor collateral. And till now, there is no proven intervention to treat those affected patients. So there was a couple of RCT for the bypass surgery, and all of them are showing the high risk for the procedure. So like the initial attempt to treat those vulnerable population include the surgical technique until the intracranial artery bypass randomized controlled trial showed no benefit surgery. And the subsequent focus was on identifying the high-risk subgroup with the poor collateral and impaired cerebral hemodynamic. So this led to the study, the carotid occlusion study, and the RCT, this RCT was stopped, despite there was a good result in terms of prevention of recurrence, but it was stopped for the fatality and the high risk of the periprocessional stroke or death. And another hopefully promising RCT study for the bypass surgery is still to get the result to be published yet. But the second interim showed the low incidence of a stroke in the surgical group. So what about the endovascular treatment? There are some publications that are mainly focused on some case reports or case series, but still the success rate is good, reaching up to 70%, with the low complications rate up to around 5%. So how to define those patients with symptomatic ICA occlusion? By the evidence in neuroimaging, there is a lesion plus neurological symptoms and or ipsilateral hypoperfusion through one of the modality to assess the cerebral hemodynamic. And the chronicity is 2 weeks or more. And at this meta-analysis, they included whatever was mentioned as a chronic, regardless what kind of the duration, just with the term chronic. And the medical therapy for the intervention medical therapy versus endovascular surgery for the medical therapy is like the best medical therapy in terms of the pharmacological versus and non-pharmacological for the coronary risk factor. Yet because still we don't have certain regimen or guidelines, so the single or dual antiplatelet, both of them included. And for the endovascular surgery, whether it's with embolic protection or without embolic protection devices were included, with the certain criteria for the to measure or the primary efficacy outcome. As here for the primary efficacy outcome is the recanalization success, defined as the deployment of the stent and restoration of the anterior grade flow without acute re-occlusion. And the primary safety outcome was symptomatic ischemic and hemorrhagic at 30 days. whenever there is neuroimaging evidence, but only would be considered if there is neurological symptoms. The secondary outcome were symptomatic ischemic event, including stroke or TIA, and periprocisional event and mortality at 30 days, and long-term follow-up for more than 30 days. So we have the periprocisional period up to 30 days, and more than 30 days is the long-term follow-up. And the mortality included all causes of death. The study characteristic included more of kind of studies or patient participant on the endovascular arm with 750 and around 300 for the medical therapy. And the main time for the long-term follow-up was about 26 months for the medical therapy, for the endovascular surgery, and up to 56 months in the medical therapy. For the primary efficacy outcome, the recanalization, successful recanalization was achieved in up to 74%. And for the periprocisional events, it was about the ischemic or hemorrhagic in 2% each of them. And for the recurrent ischemic event after the endovascular versus or the medical therapy on the long-term follow-up, it was about 12% with the endovascular therapy, and then with the medical therapy around 19%. About the other events and mortality, about around 1%. So it was about 1% for the medical therapy and 4% for the surgical group. So for this modality, we said the cerebral hemodynamic playing a critical factor, and there has to be evaluation for the cerebral hemodynamic before the revascularization, especially that it was mentioned or noticed that the highest risk population, they will have like more recurrent despite the medical therapy by 2 years, with increase up to 24%. Some biomarker or some criteria that they also noticed that could predict successful recanalization. The shorter the segment, the proximal untempered carotid artery stump, that could hint for successful recanalization. Also through the 3 Tesla perfusion imaging and 3-dimensional T-weighted imaging, if there is a high intralaminar signals that associate with successful recanalization for young and more younger and a fresh plaque. On the other hand, when there is collapsed vessels, which was identified in 90% of the cases in failed re-occlusion. So these were some possible predictor for the recanalization. So that's what was about the cervical carotid occlusion, the ICA occlusion. What about the intracranial? There are a couple of case series, and one of them most recent published last year about the effect of endovascular recanalization on symptomatic non-acute occlusion of intracranial arteries. Almost still the same, in addition to other 3 case series, almost concluding the same. There is some efficacy and safety for this procedure. For this study in the ICA occlusion, the recanalization was achieved in up to 86%, and the complication rate for the duration of 7 days, it was around 4.5%. And the MRS, achieved MRS by 90 days was about 77%, 0 and 1 in 14, around 15%. So the safety and the efficacy we could appreciate it, but still more studies are needed for this intracranial carotid occlusion. So in conclusion, through this meta-analysis, systemic review, and the case series, it showed that the recanalization rate success could reach up to 74%. The safety profile was high, with some pre-procedural ischemic stroke and hemorrhagic stroke by 4% at 30 days. And in the long-term symptomatic event, 12 versus 19 for the medical endovascular group versus the medical group. So the endovascular surgery is a promising, innovative therapeutic approach, and the technique may be superior to the optimal medical therapy alone. More effort is needed to categorize those patients and to identify them and risk group, and before we could proceed to more studies for randomized control studies. So that's it for my talk.
Thank you so much, Dr. Nouf. That's very fruitful again, but I think you took a bit of a longer time. That's completely fine. That's okay, I'm just joking. But Dr. Andrew, and also for your case, we are more than happy to receive any question for the two previous lectures now. So if you have any question for them, please write it in the Q&A box. And I would like to start maybe by Dr. Andrew. I will start my question before any other or anyone else typing their question. What do you think about using the apixaban in those ESUS case when you are almost sure that it's cardioembolic, but you actually cannot catch the reason, the accurate reason, but there is some, let's say, an atrial cardiopathy, there is atrial enlargement, the patient most likely has a cardioembolic stroke and came, let's say, twice. Are you going to use apixaban, just say that this is my expert opinion, or the evidence is not enough?
Yeah, I think that twice is the key word. I think, it's I think probably hard to justify for the first event. But, when they have a recurrence on antiplatelets, we know the safety profile of apixaban is so good from a major bleeding perspective. It will cause more minor bleeding than aspirin, no question. But major bleeding is equal, if not safer. And that's really reassuring for clinicians. So when you are faced with this, and we all are sometimes faced with these sort of niggling, looks cardioembolic, but I'm not sure, then I think you're reasonably justified with a good, I would document it well with the families that this is the rationale, that the randomized trials show good safety. We're not sure if it works better, but you've had another stroke on aspirin, right, on antiplatelets, and we're going to try this. I'm also fascinated to see how Oceanic and Librexia trials work out, because that's add-on therapy, right? A factor 11 inhibitor, which is a pretty safe anticoagulant from the phase 2 trials. Could just a little bit of that plus an antiplatelet be the perfect cocktail for these cases? And we're going to find out, I think, in the next 2 years. But I think it's justifiable to consider apixaban especially I think if there's a recurrence on antiplatelet. I think that's probably the key thing.
So do you prefer apixaban or do you prefer other agent, DABI
From a
or
safety
Riva?
perspective, from a safety perspective, you've got the strongest data head-to-head with antiplatelets. Rivaroxaban has more bleeding than aspirin from Navigate ESUS. That's very clear. But you don't see that with apixaban in any of there's 4 different apixaban versus aspirin trials now. And they all show the same trend, right? The same or less major bleeding, but increased minor bleeding. There's definitely increased minor bleeding from apixaban over aspirin. So, and that's probably mostly on the GI side, right? So you do need to kind of have a careful conversation with families. But yes, apixaban is my go-to. And, all the real world data points in that direction as well in terms of safety. It's got the safety profile advantage.
Yeah, absolutely. Totally agree with you. I have also one question for Dr. Nouf. So, Dr. Nouf, you mentioned that with your case, when the patient presented at the beginning, whenever the blood pressure, the systolic was below 160, so the patient will have the recurrence of the symptom, or let's say a TIA symptoms maybe. What was your target blood pressure at that time? Because I know, and you said for 3 weeks you waited. So what was your target? Sometimes it's really difficult to explain to other physicians that will keep the patient on a high blood pressure for a long time, for a month or 3 weeks. What was
Yes.
the target and what was your justification for that?
Yes. So actually, for this patient, he had the symptoms 3 weeks ago before presenting to our hospital, but he was at the time of the presentation, it was only 1 week. So he was treated in another hospital 2 weeks and then presented to us. So the admission in our hospital, it was only for 1 week. So from the start, the first 3 days, when we noticed that whenever the blood pressure is dropping and we try to augment the blood pressure with the IV fluid, and he's recovered. So we couldn't even wait for more than like 3 or 4 days to think about other solution. Even we try to transfer the patient to other hospital if there is any chance to do. At this point, it was difficult to keep the patient only with the blood pressure, augmented blood pressure. Thanks God, his cardiac status was okay, so he was able to tolerate this IV fluid. But it was difficult to keep him with only this solution.
Okay, so does it mean that you have to keep it above 160 for the whole
Yes.
duration? What about if it reached 200 or 220 5 days after his presentation? Are you going to drop it or you
No,
will not? I
actually,
think that's tough, right? But
yeah, it's
what
tough.
to
It's
do?
tough, and we have to monitor and see the trend of the blood pressure. How is it? So there was no target, at least the minimum is not less than 160, but for sure it's not like more than 200 or to treat if there is any hypertensive emergency or something. So we need to target, it's definitely less than 100, 200, I mean. So it was about this range, 160, 180, that where we could keep the blood pressure. But in a drop, unfortunately, the patient will have the symptoms just in front of us.
Okay, thank you. What do you
It's a
think
great
about that,
topic.
Dr. Andrew?
Yeah, it's a great topic. I mean, I think what we're learning in, Interact 4 has taught us even more about this, in that, in ischemic stroke, we need to be very ginger about blood pressure. And we may come a day where we realize just leave it alone. Leave blood pressure alone for the first 4 or 5 days. Let the human body decide what the blood pressure be. Don't intervene. Because every time we've tried to intervene, we make things worse, right? We've got randomized trials, post-reperfusion that are showing harm. We've got a trial of ARB in the stroke unit within 72 hours that showed a trend toward harm. I think, and we're also seeing some evidence that, holding blood pressure pills might be better than continuing them, although that's controversial too. So I think there's this general trend toward being much more passive with blood pressure in ischemic stroke. Of course, the opposite probably is the case for hemorrhage, but that's another conversation. And so, it's examples like this case, right, where clearly the hemodynamics are so borderline that just a little drop in blood pressure causes problems, right? And this is a common scenario with a carotid occlusion, especially if there's poor Walesian collateral support, et cetera. So this is, I think there's a trend here toward being more passive with blood pressure. What the higher ceiling is, I think we have lots to learn there, right? Is it 220? Is it 200? I think we have to keep studying it.
Yeah, that's tough actually. I will leave the floor to Dr. Saada. I think she has a few questions. Yeah, Dr. Saada.
Yes, thank you so much. I have couple of questions, Dr. Andrew. Before that, I will agree again more about this difficulty in managing the blood pressure. I remember this patient very well. It was a nightmare for him just to be seated on bed. Imagine that, how quality of life it was. So still lots of things about the blood pressure we need to know. My question, Dr. Andrew, regarding the cardiac MRI in exploring the LV thrombus. How common you use it? Because in our facilities, the request for MRI cardiac is usually mainly as from the cardiology, and we don't have that ease request the MR cardiac. So my question, how frequent and you are using it in your practice in patients whom you are suspecting that the cryptogenic cause for the stroke is may be related to the LV dysfunction and LV thrombus per se?
Yeah, I think we're only ordering probably in 2 or 3% of the stroke patients we see. It's a fairly specific thing. So I think about it in 3 settings. A high suspicion for an LV thrombus. So you have, let's say, some apical hypokinesis. You might even anticoagulate with apical akinesis and not bother with the cardiac MRI, right? You see apical akinesis, you say that's enough for anticoagulation. So you might make that argument. But let's say there's apical hypokinesis, and you're wondering, is that the cause? Then your gold standard test for a cardiac thrombus in the apex is definitely cardiac MRI. So I would order it in that setting. I would also consider it in anything that's a cardiomyopathy, like some sort of the echo is abnormal. They're thinking it might be some kind of cardiomyopathy. They're a little bit vague about it. The EF is a little bit reduced. That's a great place for a cardiac MRI. It's really good at separating out HOCM from dilated cardiomyopathy, from ischemic cardiomyopathy, and other conditions. So really helpful. They also look at the amount of fibrosis in the wall. And so this cardiac amyloid, which now has therapies, can also be detected. So it's really good when there's any hint of some kind of cardiomyopathy on the transthoracic echo. And then the last place is cardiac mass. It's really the gold standard to look at masses and to characterize what they are and sort out whether they need surgery or not, right? So those are the 3 places where I would use them. I would amp up to do it if someone had recurrent embolic strokes and you can't find anything, because it'll pick up these really weird things like discompaction syndrome and other things that might be the cause. I remember one case that I was shown in Australia by a colleague of a patient who had multiple recurrent strokes, and they had done multiple TEs that were negative, and they looked very cardioembolic like strokes. And so I suggested to him a cardiac MRI and went off back to Canada, and he actually emailed me 2 weeks later and said, we did a cardiac MRI at your request, and there was a thrombus. We were shocked. So it's that kind of situation where it's sort of a great test near the end when you're really struggling to find a cause.
Thank you so much, Doctor. I have actually another question, but I think I will leave it to the end. And I will now go further with the second case study presentation. Allow me please to introduce Dr. Muath. Dr. Muath Ahmed is the Neurology Senior Registrar and Stroke Fellow F1 at the Ministry of National Guard for Health Affairs, specializing in stroke treatment and prevention. He is dedicated to advancing the patient care and outcomes through his expertise and commitment to the Neurology Department Stroke Program. Welcome, Dr. Muath, and the floor is yours.
Thank you. Oh, yeah. Thank you, Dr. Sauda, for introducing me. Thank you. Welcome, everyone. So today we're going to present a case about IV thrombolysis therapy and endovascular mechanical thrombectomy with low aspect scope. This is a case that I have seen during my own call. She's a 33-year-old female, not known to have any medical illness and not on any medications. She was brought to the emergency department with sudden left side weakness and associated with left side headache and drowsiness. Last time seen Will was 3 hours and 20 minutes before presentation. She had no previous similar symptoms, and she had a positive history of stroke in young, her uncle at age of 36. Her pre-MRS score was 0. And during her examination, blood pressure show was 135/108, with normal oxygen saturation and heart rate and respiratory rate. Random blood sugar was within normal ranges, and ECG showed normal sign of rhythm. Her NS score was 12, with left side weakness, left face, upper and lower limbs, with left homonymous hemianubia, with a picture of right MCA stroke. This is the CT brain stroke protocol. The non-contrast CT showed a an early ischemic changes in the right MCA territory with an aspect score of 2. The CT angiography showed a right terminal carotid occlusion, and the CT perfusion showed a mismatch between the Tmax and the cerebral flow. So in summary, this is a case of 33 years old female, medically free, presented to the emergency department with acute right MCA ischemic stroke within 4 hours window. NI score was 12. The CT brain stroke protocol showed aspect score of 2 and right T occlusion. So our question today is, which reperfusion therapy will you consider in such a case? Are you going to give a TBA and do endovascular mechanical thrombectomy, or only giving the TBA, or you are going to do a direct endovascular mechanical thrombectomy, or you think this patient is not a candidate for IV TBA nor endovascular mechanical thrombectomy?
Okay, Muath, are we going to take the poll, or there is the
Yeah,
poll, or there is no do it?
I think there is the poll.
Okay, so I would like to interrupt with you and discuss with you the case here as we did it together. So if you go back to the previous slide of the images, what I found strange about this case when we discussed it together before, that in the non-enhanced CT brain, you can see that there is a large area of what seems like an established infarct, almost involving all the areas. Maybe the M3 is not that involved. But when you look at the CT perfusion, there is a huge mismatch between the core and the penumbra. And she presented yearly within only 3 or 4 hours from last time seen well, and she's only 33. So if you ask me the same question, initially when I look at her image, I just say like, oh, I think she's not a candidate for any. She has a very low aspect of, seems like 2 or 1. But when I look at her CT perfusion, I'm a bit confused. And on the same time, she's quite young and she is presenting very early with maybe the latest evidence. And I'm sure that you will talk about that. I will go for thrombectomy, but for me, for a TPA, I would say it's a definite no for me. But what about the other people? Did they vote?
I'm not sure if the vote is displayed or not, but I've been told that there's going to be a vote for, and the result will be shown for 20 seconds.
Okay, so let's wait for a few seconds. Maybe during that time, we can hear from Dr. Andrew. What do you think, Dr. Andrew? If you are still with us. Okay, so let's see Dr. Saada. Dr. Saada, what do you think?
Really, I cannot agree more with Dr. Nuran. It's a very tough thing. But as you mentioned, what makes me maybe more thinking, yes, definitely with the endovascular, is that she is young, and the results of the perfusion study, which was really I did not expect to see with the after seeing the plain CT. So a big no for the TPA.
Okay.
And the poll for me with the direct endovascular.
Okay. Yeah, so we're on the same page. I think maybe we will not have the results. So Muath, you can proceed.
So IVTBA and low aspect score. So in one study of the importance of early. Sorry, I cannot see the. Okay, of early ischemic changes on CT brain using aspect and NINS TBS stroke study. This is an article, a study that was published in September 2005. They examined whether aspects could be a treatment modifier by systemically reviewing the CT scans in NINS TBS stroke study. And to better understand this, they trichotomized the aspect score into 3 groups, with a group more than 7, aspect of more than 7, and the other group is aspect from 3 to 7, and the third group was aspect of score of less than 3. In every case, the TBA or IV thrombolysis therapy improved the proportion of patients achieving an excellent function outcome, as you can see in the figure on the right side. However, the aspect group of less than 3, mortality was increased with TBA compared with placebo. So they concluded that their study is consistent with the previously published reevaluation of the NINS TBA stroke study for early ischemic changes on CT scans using the 1/3 MCA rule, which found benefit from TBA even if more than 1/3 MCA territory is involved. Therefore, exclusion of patients for thrombolysis within 3 hours of symptoms onset based on early ischemic changes is not supported by their data. Another trial here is a retrospective study of the ECAS-2 patient data was to assess if baseline aspect on presentation could predict favorable outcome and or incidence of secondary hemorrhage in patients treated with TBA within 6 hours of symptoms onset. They retrospectively assessed 800 patient baseline CT scans and dichotomized aspect at greater than 7 and 7 and below. There was no treatment by aspect interaction with dichotomized aspect up to 6 hours. However, there was a treatment by aspect effect modification in predicting parenchymal hemorrhage. In the below table, you can see the rate of symptomatic intracranial hemorrhage. For patients with aspect more than 7, the symptomatic intracranial hemorrhage was 6.4% risk, and the risk of symptomatic intracranial hemorrhage for aspect from 0 to 7 was almost doubled, 14.5. And as in our case, the aspect of 0 to 3, the risk of symptomatic intracranial hemorrhage was 40%. So they concluded that on the basis of their current and previous work, they believe that assessing early ischemic changes with aspect adds important information to patient selection for thrombolysis beyond 3 hours from onset, and their results were consistent with the previous studies that patients with early ischemic changes, even if more than 1/3 of the MCA within 3 hours, this is a net exclusion for an IV TBA. This is the HASA guidelines in 2019. They said that there remains insufficient evidence to identify a threshold of hypoattenuation severity or extent that affect treatment response to alteplase. And they stated clearly that severe hypoattenuation, defined as obvious hypodensity, represent irreversible injury, is a clear contraindication for TBA. So they did not specify how big is the attenuation or the threshold of attenuation to state this patient as a clear contraindication or not, but only a clear and severe hypoattenuation is a clear contraindication. And in regards to endovascular mechanical thrombectomy and low aspect score, this last trial of thrombectomy for stroke with large infarct of unrestricted size, it's a recent trial published in May 2024, multi-center prospective open-label randomized clinical trial. They assigned patients in 1:1 ratio with patients with proximal occlusion in the anterior circulation and large infarct, as defined by aspect score of 5 or less, detected on MRI or CT brain within 6.5 hours after symptoms onset. This study, a unique thing about her, that the majority of patients had a very large infarct with aspect value of 2 or less. Patients with similarly large infarct were generally excluded from previous other trials. Furthermore, the median baseline infarct volume of 135 ml in their trial was larger than in other trials. This trial was stopped early because the results of similar trials favored thrombectomy. They concluded that patients with acute stroke and large infarct of unrestricted size of aspect score of 5 or less. Thrombectomy plus medical care resulted in better functional outcome with number needs to treat of 4 and lower mortality than medical care alone. You can see in the displayed figure here in the middle part, it is describing the patient with baseline aspects value of 2 or less. And you can see that they had the thrombectomy plus medical group and compared to the control, which is only medical therapy. They had a better functional outcome and a lower mortality rate. However, they had a higher incidence of symptomatic intracerebral hemorrhage. In the below table, we can see the rate of symptomatic intracranial hemorrhage according to Heidelberg classification. In the thrombectomy group, it was 9.6, and in the control group, it was 5.7%. So the decision was made not to give IV TBA, and the patient underwent direct mechanical thrombectomy in our case. For take-home messages, areas of marked hypodensity suggesting that the stroke is more than 4.5 hours should give the physician a pause. Early ischemic changes on the CT brain within 3 hours window are not an exclusion for IV thrombolysis therapy. And early ischemic changes with aspect adds important information to patient selection for thrombolysis beyond 3 hours from onset. Based on multiple randomized clinical trials, there are subgroups of patients who might benefit from endovascular mechanical thrombectomy in low aspect 3 to 5. And more studies need to be conducted to evaluate the benefit of endovascular mechanical thrombectomy in aspect score of less than 3. Thank you.
But Muath, just before we conclude this case, so are you convinced to give this patient TPA even her aspect is 2?
Well, the
What do you
patient
think?
at that time when was the decision had to be made, the patient ischemic stroke was 4 hours ago. So
Okay.
beyond the 3 hours, with the aspect score of 2, and it was very low score. So I agree with you, doctor, that based also on the results of the second trial that I mentioned, that the risk of symptomatic intracranial hemorrhage from aspect from 0 to 3, it was 40%. So it
Okay.
was a little bit high. So I wouldn't give TBA for this patient, especially that we have the facility in our center for endovascular mechanical thrombectomy.
Yeah, I agree with you, but on the same time, not like to give the people the wrong message. I believe that in her CT scan, even if it was within the first 3 hours, there was an obvious hypodensity just talking about this case CT scan. And it will be quite risky to give TPA. You have usually to keep in your mind the risk of symptomatic ICH, and as you mentioned, it's higher and higher when you have a lower aspect. And as you mentioned, when you have an endovascular therapy, just go for that in such case, because the harm that you can put or you can cause to your patient, I think, will not be that much justified. So we can just say that's more than 1/3 of the MCA is involved, and that's it. Okay, so thank you so much. We'll leave the floor for Dr. Saada. This was our case from the National Guard.
Thank you so much. Thank you for this very interactive session. And I do believe, yes, that the main aim is not, of course, harm the patient. And being a large vessel occluded and a big stroke with availability of the mechanical thrombectomy and the results that the yield that we'll get from the IVTPA in a large vessel occlusion in terms of recanalization will not overweigh the harm of having the bleed and most likely recanalization with the mechanical thrombectomy. So concluding our case, we will move to our speaker, Dr. Nuran.
Okay. So our next speaker is Dr. Hani Sabbour. Dr. Hani, he has over 29 years of a clinical experience in all aspects of cardiology and extensive academic experience, starting from his training at Harvard Medical School and a clinical assistant professorship at the Brown University. And he's currently working at the Mediclinic Hospital in Abu Dhabi, UAE. Today, he will be talking about atrial fibrillation, the current Okay, sorry for that. The current understanding, monitoring, and management, which is quite important for us and linked to the previous lecture presented by Dr. Demchuck. Dr. Hani, we are glad to have you with us tonight, and please go ahead.
Thank you very much for the very kind introduction and the invitation. I think we always have to work as groups of physicians, and I think when we have these multidisciplinary meetings, they're extremely valuable because the combined learning is very, very important. So I'm actually going to talk about a little bit beyond the conventional approach in stroke prevention and anticoagulation. I want to talk a little bit about AFib management in terms of rate versus rhythm control. And I think this is something that's emerging as a very hot topic in the guidelines. And I think it's a very important point from a clinical standpoint as well. This is my contact information if anyone wants to reach out to me. So what we want to do is look at three different things. Look at the major management strategies to control atrial fibrillation itself. Look at the rationale for rate versus rhythm in specific cases, and look at recent studies supporting ablation in the management of AFib. So here's a very typical case from my clinic, a 71-year-old woman for a regular checkup. She has a history of hypertension and a BMI of 33. She was found to have previously undiagnosed AFib with rapid ventricular rate, and the blood pressure medication, she's on enalapril and atorvastatin. So clinically, she's normotensive, heart rate's about 125, she's afebrile. The rhythm is irregular, so somewhat tachycardic, and no focal neurological signs. She's alert. Her labs are as follows: mild hypokalemia, normal platelet count, normal hemoglobin, and a normal thyroid function test. So the chest X-ray is also unimpressive. The echocardiogram shows a severely dilated left atrium, no significant valvular heart disease, normal ejection fraction, and she had a normal coronary angiogram on a cath 1 year ago. So this is her ECG, and you might recognize a couple of things here. So first of all, it's irregular, and you may look at the V1 leads, and you see a very unusual looking atrial signal, and you could be fooled into saying this is atrial flutter, but if you look, the cycle length is not completely regular. So it's most likely a sort of a more organized type of atrial fibrillation than true atrial flutter. So the average heart rate on the Holter monitor is about 98 beats per minute, but she does get up to 141. Remember, she's about 70 years old. So, what would be the best management in a patient at this time? So initiate a direct or novel anticoagulant and bisoprolol for rate control and monitor in a Holter in 2 weeks. Initiate the anticoagulant and amiodarone 200. Initiate the novel anticoagulant and have a TE cardioversion, and then maintenance with sotalol or some antiarrhythmic. Initiate warfarin and do a chemical cardioversion with oral flecainide with maintenance flecainide dosing or some other strategy. So all of these are in the realm of possible. I think it's fairly clear that in a patient like this with a CHAS-VAS score above 3, warfarin would not be a good option because we know that there's a significant risk of bleeding with warfarin in these patients. And clearly the NOACs have that tremendous advantage. And this is obviously non-valvular AFib. So I think all of these choices are reasonable. Then the other question is, what do you do about the rhythm control? So what if this is a younger patient? Maybe it's a 45-year-old who has dyspnea and moderate exertion. The ejection fraction is about 40 to 45%. You have a dilated left atrium, no valvular heart disease, and there's mild volume overload. So now there's a slightly different phenotype where the atrial fibrillation may be contributing to the heart failure. So, what would you do there, right? And what contraindications of antiarrhythmics? So, as an electrophysiologist, we spend a lot of time choosing antiarrhythmics, and there aren't that many. So amiodarone has issues with liver, thyroid, and lung function. Sotalol, significant QT prolongation and proarrhythmia, especially when bradycardic patients. Flecainide cannot be used in patients with ischemic heart disease. Propafenone is quite similar. So we can think about the possibilities in this patient. So when you're looking at atrial fibrillation, there's many things beyond anticoagulation. I know the huge focus is anticoagulation because that's the lethal complication with stroke, of course. But what about risk factor management? Can you decrease the likelihood of AFib through obesity management, through diabetes management, through heart failure management? What about rate control and rhythm control? What's good for the patient? Do they have a lot of symptoms? Is the heart failure being driven by the arrhythmia or not? So beyond 2019, we had a change in the heart failure and the arrhythmia guidelines, specifically driven by 2 randomized clinical studies. And then the next point is, what are you trying to do for the patient? Longer life, better quality of life, curing the atrial fibrillation. And what is success? Complete elimination of every single beat of AFib or reduction in the AFib burden. And what is the patient doing when they're making these decisions? Are we involving them in the risk-benefit relationship? So there are very few rhythm control drugs. And in fact, they're basically, you see everything here on this table. So amiodarone is the famous one. We have sotalol. The only new antiarrhythmic in the last decade has been dofetilide, which has a lot of proarrhythmia and a lot of specific issues about its prescription. Flecainide, mexiletine, diazepamide, and quinidine. And as you see, nothing has really changed since the 1980s. There's not a lot of investment in antiarrhythmic therapy, and all of these have specific side effects. In terms of rhythm control, you have beta blockers, calcium channel blockers, and digoxin, and that's basically all of it. So what's new is in the 1990s, and I remember this when I was a fellow in Boston, the new thing was ablation. And ablation was a very complex procedure at the time, but it was realized that most of the atrial fibrillation comes from the pulmonary veins, not from the atrium itself. And if you can ablate the focus or eliminate the connection between the pulmonary veins and the atrium, you can have a significant impact on reducing AFib burden. And there's ways to do it using electroradiofrequency, which is a direct point-to-point ablation, or special cryo balloons that help seal the hole and create a circular ablation lesion. So if you look at the old studies of AFFIRM, so AFFIRM was a different kind of study. It looked at patients, 4,000 patients, rhythm control versus rate control, using what? Using antiarrhythmic therapies, right? And of course, we know that sinus rhythm is generally something good, but the bigger problem is when you use antiarrhythmics that have a lot of toxicities and prolong the QT interval, there was actually an increase in mortality. Not a significant one, but something that would be fairly clinically important, even if it's not significant. Now, they had older patients, heart failure, they were symptomatic, and they had dilated left atrium. So the likelihood of rhythm control was actually lower. So does it actually tell you that rhythm control is bad, or maybe the tool we use for rhythm control is not the right one? So AFFIRM actually showed a very close all-cause mortality, but it was statistically but clinically significant, but not statistically, higher mortality in 5 years. The mortality benefit, however, was offset by the increased mortality with antiarrhythmic drugs. So in some studies with AFib and heart failure, it became more clear that the rhythm control was even more important in these patients. So unfortunately, the AFFIRM study left many things unanswered because it did not cover the majority of patients that you see in your clinic. What about a young patient with lone AFib? What about patients with thyrotoxicosis who have AFib? What about patients with SVTs that have AFib and patients with WPW and risk of sudden death? And of course, the most important one, this is the prototype, the tachycardia-induced cardiomyopathy. These patients, the atrial fibrillation drives LV dysfunction and makes situations worse. And there's one group of patients that's very common, atrial fibrillation related to obesity and obstructive sleep apnea. So the population in the US is getting older, and data in patients with atrial fibrillation is following the population as well. So the increase in atrial fibrillation is actually happening in the older age group, as you can see from this graph. More patients, on the other hand, with paroxysmal AFib are younger, and they may require a different strategy than long-term antiarrhythmics. So we have now the Cabana study, and this is a very controversial study, and it depends if you're an electrophysiologist, you think the results are positive. If you're everybody else, you don't think it is from a statistical standpoint. But let's look into what we got from this study. This was a randomized clinical study comparing ablation versus antiarrhythmic drug therapy and looking at hard endpoints, stroke, mortality, bleeding, and cardiac arrest in patients with atrial fibrillation. And there was a sub-study that looked at the quality of life in those patients undergoing ablation. So the idea here was to look at comparison side to side of therapies that are different that both lead to restoration of sinus rhythm. Now, the problem in this study is this very large crossover. So if you're going to an ablation therapy study, you're being enrolled by an electrophysiologist, and electrophysiologists like myself do have a bias that we believe that ablation is a more effective and cleaner therapy. So there were 1,000 patients randomized to catheter ablation and 1,000 patients randomized to drug therapy. In fact, in the drug therapy arm, only 301 received ablation, and in the catheter ablation arm, about 100 did not get ablation, actually got therapies, or had a second ablation. So it's a mixed study. In reality, there's so much crossover. 27% of the drug patients actually got catheter ablation, in spite of the fact they were initially enrolled in drug because the doctor felt they failed. And so there you have to look at the statistics with some degree of detail. Now, they did have younger patients, about a third. They had older patients, about a half of these patients. There was a good distribution between men and women. All races were represented, and they did have patients with elevated BMI, which represents about the population similar to the Middle East, and they did have significant heart failure. Lots of comorbidities in these patients, and also the CHA2DS2-VAS scores, as you see, were significantly elevated up to CHA2DS2-VAS scores of 5. So what was the endpoint, the cumulative endpoint of death, stroke, serious bleeding, or cardiac arrest? So you see catheter ablation had a lower event rate, and it was 14% less. However, the p-value is not statistically significant. So as a purist statistician or clinical epidemiologist, you'd say this is a negative study. However, and the mortality, again, was lower numerically than drug therapy, 15%, but not statistically so. On the other hand, if you looked at mortality or cardiovascular hospitalization, a combined endpoint, it was statistically significant and numerically about 17% less than drug. Remember, the comparator here is drug, not placebo. When we looked at the secondary endpoint, which was freedom from atrial fibrillation, clearly catheter ablation was superior in reducing the frequency of recurrence of atrial fibrillation than drug therapy. And they actually did something called blanking, where they didn't know what was going on. Then they used a electrocardiogram, systematically event recorders in patients to see if they had any kind of atrial fibrillation, not just symptomatic AFib. And one of the other points, of course, that was discussed in the paper is the intention to treat analysis. So if you looked at the per protocol analysis, and this is kind of an important point, those patients who were on drug and remained on drug, and those patients on catheter ablation who got catheter ablation, at 6 months, there was a 26% reduction. And at 12 months, it did become statistically significant, almost 27%, with catheter ablation being significantly better. So this actually was the patients that actually received the risk-acquired therapy. And this is where the crossover becomes important. So the outcomes here are, as you see. In fact, the quality of life scores were significantly better with ablation than drug therapy. Maintenance of sinus rhythm was better. And I think you can make your own conclusions about what this study is telling us. Is it saying that drugs are equivalent to ablation? I think the answer is no. From a patient standpoint, having the reduction of atrial fibrillation is really why they go into these procedures as well. So the quality of life, actually, I think, was one of the important secondary endpoints. And I think you can see here that at 3 months, 12 months, and at all time points, there's a significant improvement in quality of life through greater reduction of AFib burden. And in fact, in terms of looking at AFib frequency measured by event monitors, again, compared to drugs, catheter ablations are a lot better for these patients. So while the statistical conclusion, we did not get a significant reduction in primary endpoint and all-cause mortality, there was a lot of directional crossover, lower than expected event rates. However, if you combine mortality and CV hospitalization together with ablation, there was better compared to drug therapy. There was a 47% better reduction of recurrent AFib with ablation compared to drug therapy, because it's actually addressing the substrate that in a very specific manner. And in the patients who actually underwent ablation, not just randomized to ablation, actually did have ablation overall, and that came from both treatment arms, there was a 33% reduction of primary endpoint and 40% mortality risk reduction when the treatment was received. So I would say that my conclusion from a clinical standpoint that ablation is an acceptable strategy, treating AFib with a low adverse event rates, even in higher risk patients, and improves what the patients are going in for. That is improvement of quality of life. So the other very important study that informs our decision is this study. This is called the Castle AFib study. So this is looking at ablation in patients with heart failure. And this was a smaller study, but you'll see almost within 6 months, there was a very significant reduction of death or hospitalization for heart failure. So these are not just AFib patients with symptoms. These are AFib patients who are even at higher risk with heart failure. And the ablation patients continued over 60 months to have a better outcome, which continued to diverge. Medical therapy, i.e. antiarrhythmics and heart failure therapy, was inferior in this regard. So death from any cause, which is all-cause mortality, remains statistically significant, almost 50% by end of study, and hospitalization for worsening heart failure continued to improve month on month if you were in an ablation arm. So this means that in a specific group of patients with AFib and heart failure, a significantly lower composite endpoint, death from any cause, which is a very hard endpoint, or hospitalization than medical therapy. So this has led to a change in the guideline. Based on this evidence, and this is a very powerful randomized clinical study, it is suggesting that catheter ablation is reasonable in patients with symptomatic AFib and heart failure with reduced ejection fraction to lower mortality and reduce hospitalization and heart failure. And this impact on mortality has actually been specific to catheter ablation compared to medical therapy in patients with heart failure. So when I come in the clinic, I need to sort of integrate this information and have a good description to the patient. Again, this is an invasive procedure, and the patient has to understand the risks and benefits. What would favor rhythm control? Younger age, less than 65, more symptomatic from the AFib itself, paroxysmal AFib or recently detected AFib. In other words, there hasn't been remodeling. The presence of heart failure clearly triggered by the atrial fibrillation. Patients who are not on antiarrhythmic therapy and have not failed antiarrhythmic therapy. And of course, patient preference. And many patients will tell me, doctor, I cannot breathe or walk when I have atrial fibrillation. Persistent atrial fibrillation, long-term large left atrium, no prior history of heart failure, and previous antiarrhythmic drug failure means it is less likely that either drug or ablation will work. And I think the elderly patient who has more risk during the procedure is important too. But what I'm pointing out to you here, you don't see anything about stroke in this calculation, right? So in fact, even if I have a highly successful AFib ablation and the patient remains in sinus rhythm 6 months, 1 year, 2 years out, if the CHA2DS2-VASc score would indicate a need for anticoagulation, we do not stop anticoagulation because the risk of stroke is not mitigated even by successful ablation because it's really the substrate of the myocardium. And you know you have patients who have a stroke during sinus rhythm in paroxysmal AFib. So it is a complex algorithm and it's a lot of different branching points. But I think the key point is if a patient has a high likelihood of success, highly symptomatic, and also having a cardiomyopathy, this is a very important point to try and really modify and improve the success of AFib ablation. If a patient has a less symptoms and they stabilize on rhythm control and they don't have heart failure or any of the high-risk features, it's entirely reasonable to leave them on rate control only. And the important point is if you cardiovert the patient and they feel exactly the same in atrial fibrillation or sinus rhythm, there really is no benefit to going for an ablation procedure. And therefore, maybe in this case, using an antiarrhythmic is reasonable. So there are multiple different branching points here, but yet in the end, no answer is completely correct, either from age standpoint, comorbidity standpoint, ablation availability, or medical therapy. So there are also some specific advantages of rate control. It's simpler, the medications are easy, and they don't have a lot of proarrhythmic side effects. And if you stay with rate control, maybe you have an elderly patient who doesn't have a lot of mobility or symptoms, then the patients will not have to have recurrent cardioversions and hospital admissions. And it's obviously a cheaper strategy. Rhythm control clearly has an impact on reducing the amount of atrial fibrillation and also associated symptoms. And when you have rhythm control, it actually reduces the likelihood of relapse. So as we say in electrophysiology, atrial fibrillation begets AFib. The longer you stay in AFib, the more the remodeling, the more difficult it is to get the patient out. With rhythm control, the atrial contraction is preserved. You don't get that with rate control. So this is very important in patients with heart failure. And of course, heart failure status can improve when the patients remain in sinus rhythm. And ultimately, we believe this may have a long-term impact on LV function. So just to conclude, there is no single strategy for AFib management that is suitable for every patient, and we have to individualize it. And the patient is a very important part of this discussion. Each strategy, either rate control, rhythm control, medical therapy with antiarrhythmics, or ablation, have pros and cons. And in 2024, it's very different compared to the AFFIRM study in 2002 when we were comparing amiodarone basically to placebo. And I think the final answer is this: patients have to be actively participating in the most treatable treatment strategy for them, because ultimately it's the symptoms and the quality of life that primarily drives this decision. Thank you very much.
Thank you for that, Dr. Hani. It's a great lecture, actually. And I would like to ask you a question about the ablation, because we face a lot of patients with a stroke, and then after the stroke, we diagnose them with the AFib. And in all these cases, we just start the anticoagulation. We call the cardiology for any other medications to be added. And actually, I've never faced a cardiologist when they offer a patient an ablation when they have an AFib, although some of them might have a heart failure. And
Yes.
going for ablation, as you mentioned, might improve the mortality, even if we are going to continue on the apixaban or anticoagulation. But when you have a lower mortality, that's something really important for the patient. So do you think that as a neurologist, when I have a patient with a newly diagnosed AFib and a heart failure and a stroke, I should talk to a cardiologist looking for possible ablation, or I will just say, let's keep him on the medication and that's it?
So I think this is a very important discussion, right? So when a patient has a stroke, a lot of the focus is going to be on secondary stroke prevention and rehabilitation. But we have a lot of young patients in the region, right? We have a lot of patients who come to the stroke unit at Cleveland Clinic, Mediclinic. Many patients are young and they do recover because of the interventional therapies and the TPA. So the stroke may not leave them with disability, but they still have atrial fibrillation. So I think beyond the acute event, I think we have now, there's a new approach now in the ESC guidelines. That's called the AFib management team. So it's a cardiologist, an electrophysiologist, heart failure, nutritionist, sleep apnea, neurologist. Everybody participates in this decision a little bit because there is a tremendous opportunity in heart failure patients. Now, I'm going to tell you for a fact, if you see a patient with heart failure and they're very stable and then they go into AFib, you see they decompensate very rapidly. It is a very powerful driver of decompensation. I have a very low threshold to offer ablation to these patients. Unfortunately, I think most cardiologists think of the mindset, oh, the patient had a stroke, they're disabled, they're not going to walk, it's not going to be a big deal. That's not true. All of the interventional therapies and the thrombolytic therapies and the stroke teams have made a huge impact in the quality of life of our patients. And many of them do not have significant residuals because they're treated early. So we shouldn't have this sort of blanket effect. The presence of a stroke prevents you from having an ablation. Actually, that is not correct. And I have many patients that we've successfully ablated who have not only improved their quality of life from the neurological standpoint, but from their physical standpoint from heart failure. So I think what you need to consult with in that scenario is an electrophysiologist, right? Electrophysiologists have a more, as you saw, like an aggressive mindset towards ablation. And maybe we sort of believe a little bit of things that the guidelines are telling us, and we try to implement it a little bit more. It is a technically demanding procedure. The new technologies are making it easier. And certainly with cryoablation, the procedure times have reduced significantly. And in fact, even the peri-procedural stroke risk is reduced now with the modern technologies we have. We're literally quoting patients a peri-procedural stroke risk of less than 1% when we're doing AFib ablation with the modern technologies.
Okay, sounds great. Okay, Dr. Saada, if you have any question, and also for the audience, if you have any question, please don't hesitate to type it in the Q&A box.
Thank you so much. Thank you, Dr. Hani. Now, I'm really impressed with the idea of the AFib treating team. I didn't know about such team before. And my question actually on the same line like Dr. Nuran. We have few patients that they have recurrence of stroke despite the fact that they are AFib patients on anticoagulations, on NUAC, and we all know that the secondary stroke prevention is not, of course, 100%. And if the patient develop another stroke, being compliant to his medication, and the topography of the stroke is suggestive of a
Symbolic.
cardioembolic one. And of course, there has been exhaustion of the other cardioembolic related causes for the stroke. And putting on the background that was what you mentioned, that now our stroke patients are no more that what they thought before. They are completely disabled. And we know about the shrinking deficit that is caused by most of the types of the cardioembolic stroke. Could the role of ablation in a known with a patient with AFib compliant to anticoagulation and developed another stroke, cardioembolic looking topography, could it be an option that I can ask our cardiologist that this is probably a strong indication for ablation in such patients?
Unfortunately, the data, this is what we hoped, but the data has not shown that. So when we do AFib ablation, we're modifying only the electrical substrate, not the anatomical substrate. So we've come to realize from diabetes literature primarily that patients with atrial fibrillation have an atrial myopathy. When you do a cardiac MRI, you actually see some scarring in the atrium. There's a study that was done actually in Utah, which they did cardiac MRI with gadolinium, and they actually staged patients with atrial fibrillation based on left atrial size and scar tissue in the atrium itself. And we didn't realize this until we started doing more mapping. So even if the patient is successfully and electrically in sinus rhythm, the atrial myocardium may have other ways of producing thrombus. Similar idea when we started with the left atrial appendage occlusion. We thought this was going to solve the problem because 90% of the thrombi come from the left atrial appendage. Then we had patients coming back with strokes coming from the posterior wall, from the pulmonary veins, and so on. So unfortunately, that's the one outcome that we have not been able to impact, even with the most successful ablation. And there are groups in France and some of the high volume centers in Texas that actually did very extensive ablation, literally burning every possible focus, and the thrombotic risk is not modified. So unfortunately, the secondary prevention patient who's had a secondary event, I think the real problem is that they're non-compliance. And I've seen this situation where this is the problem. Unfortunately, the DOACs have a brilliant effect, but you can't monitor them effectively, right? With warfarin, yes, there's high risk of bleeding, but I do a blood test. Listen, you did not take your warfarin. Your INR is not correctly treated. Now, with the DOACs, you do have their indirect methods like the eccrine clotting time or the thrombin time and so on. But again, the accuracy of these methods is not clear, and it's also dependent on the timing, right? So if the patient missed the dose yesterday, by the next time you see the lab tests may not reflect today's dosing. So these are very complex cases. And unfortunately, we've had patients that we've had to push them back onto either warfarin. I have a couple of patients that are now on low molecular weight heparin long-term because they failed two anticoagulants. So fortunately, these are rare. I mean, these are terrifying cases. They're rare, but the thing is, we look at the appendage, we find that the appendage has smoke, and the patient said that they took their anticoagulation a few days ago. I don't know. Sometimes I have to be a little bit skeptical. But of course, even in the big DOAC studies, we didn't reduce the stroke risk to zero. So as was very nicely shown by Professor Andrew, there are other causes on top of these patients may have a hypercoagulable state on top of atrial fibrillation, and they're just very unfortunate to have that. But so thank you. It was an excellent question, really.
Thank you. And again, I have another comment on this great trial, the Cabana trial. So what I understood that the, let me say, superiority of the ablation, it comes in terms of two things, efficacy-wise, and because we have less side effects from the antiarrhythmic medications, which are really two very important thing, that what we used to know before about the rhythm control and the rate control is now very clearly and well explained by the results of the Cabana trial. Thank you so much for enlightening this important trial.
Absolutely.
Thank you. Thank you so much, Dr. Saada and Dr. Hani. And I think we are already 15 minutes after our expected time to finish. So thank you all for being here with us today. And I really enjoyed the topics, the cases, and the discussion. And surprisingly, we don't have questions actually from the audience. I think everything was quite clear for everyone.
Very clear.
Yeah. Thank you all, and we'll see you in the next MENASO activity. And have a good night.
Good night. Thank you all. Thank you.
Thank you for
Bye
inviting
bye.
me.
Bye-bye.